Hi everyone, this is Doc Ina, and this lecture is on the pelvic organ prolapse or POP. To download this lecture deck for free, please go to my WordPress site, Doc Ina o Bigaine. The main reference for this lecture is Comprehensive Gynecology 7th edition, Chapter 20. This is the outline of our lecture. First, we define what the pelvic organ prolapse is, then discuss the pathophysiology and classification of POP, and then also discuss the different types of pelvic organ prolapse according to the anterior vaginal wall, posterior vaginal wall, and finally uterine prolapse. So pelvic organ prolapse or POP or POP is a condition characterized by the failure of various anatomic structures to support the pelvic viscera. It is defined as a descent of one or more of the vaginal walls or cervix. So for anterior vaginal wall prolapse, we have cystocele, urethrocoele, and a paravaginal defect. For the posterior vaginal wall prolapse, we have rectocoele or enterocoele, and then we also have uterine or cervical prolapse and a vaginal wall prolapse, which is seen in cases where patients underwent hysterectomy. POP is common among Paris women, and pelvic support structure defects are often associated with the following: vaginal childbirth-related injury, either neuropathy or muscular injury, stress and strain from heavy lifting, and of course the aging process. Symptoms of pelvic organ prolapse include the following: vaginal bulging, pelvic pressure, vaginal bleeding or discharge, low backache, and the need to replace the prolapse in order to void or defecate. POP can mostly be asymptomatic, but symptoms are more common when the prolapse extends beyond the hymen. These are the risk factors for the development of pelvic organ prolapse, and the most common is vaginal childbirth. We also have aging, obesity, medical conditions such as diabetes mellitus, genetic conditions or connective tissue disorders, neurologic injury. Possible associations with pelvic organ prolapse include the following: a prior pelvic surgery, hysterectomy, constipation, irritable bowel syndrome, episiotomy, higher weight of the largest infant delivered vaginally, chronic cough and respiratory diseases, exercise, heavy lifting, and lower education. For the pathophysiology of pelvic organ prolapse, normal support of pelvic organs is provided by several key anatomic structures. Level 1 support of the vaginal apex and cervix is provided by the uterosacral and cardinal ligaments and associated connective tissue. Level 2 support of the mid-vagina is provided by connective tissue attachments to the arcus tendineus fascia pelvis on the lateral pelvic sidewalls. Level 3 support of the distal or inferior vagina is provided by the perineal membrane and muscles, and all of the attachments are connected through endopelvic connective tissue. Now, if there is a failure of support of the pelvic organs in any of these levels or a combination of these levels, then that's when pelvic organ prolapse occurs. The pathophysiology of pelvic organ prolapse is multifactorial. Theoretical explanations include the following: muscle atrophy from denervation from childbirth injuries, muscle wasting from muscle insertion detachment from childbirth, and possibly age and hormonal status. Here is a model for the development of pelvic floor dysfunction in women. These are actually factors that promote or cause pelvic organ prolapse. In here we have the predisposing factors such as the gender, which of course is the female gender, the race, neurologic factors, anatomic factors, loss of collagen, muscular factors, cultural, and environmental. We also have here the inciting factors such as childbirth or multiple childbirth, nerve damage, muscle damage, radiation, tissue disruption, radical surgery. Those that risk factors that promote pelvic organ prolapse include constipation, occupation, especially when it involves heavy lifting, recreation, obesity, surgery, lung disease, smoking, because these are conditions that can cause chronic coughing, menstrual cycle, infection, medications, and menopause. The three greatest risk factors for developing pelvic organ prolapse in reproductive age women include POP during pregnancy, maternal history of pelvic organ prolapse, and current heavy physical work. For the general population, obesity and smoking may be modifiable risk factors. Genetic factors can also contribute greatly to pelvic organ prolapse. For the general symptom assessment, actually many women with pelvic organ prolapse are asymptomatic, but those with symptoms include the classic symptoms of prolapse, which include vaginal heaviness and pressure, vaginal bulge, pelvic pain, or vaginal bleeding, which is from erosions of exposed vaginal epithelium. Now, some of the patients also complain of back pain and pelvic pain, but these are not reliably associated with pelvic organ prolapse. If a woman with objective prolapse does not have any symptoms or evidence of associated medical risks such as urinary retention or renal impairment from urethral or ureteral kinking, then this patient does not necessarily need treatment. The urinary symptoms include urinary incontinence, difficulty voiding, slow urinary stream, or a sensation of incomplete bladder emptying. Bowel symptoms also include constipation, straining, incomplete evacuation, fecal incontinence, or splinting to achieve bowel movements. Sexual symptoms include discomfort, irritation, and decreased sexual desire. And this is a summary of all the symptoms that we have discussed. For the quantification of pelvic organ prolapse, we have several systems, but in the past, we usually used this system. First degree, prolapse into the upper barrel of the vagina. Second degree, prolapse is through the vaginal barrel to the region of the introitus. Third degree, if the cervix and the uterus prolapse out through the introitus. And finally, fourth degree is the complete eversion of the uterus and cervix, which is what we call PROCIDENTIA or vaginal apex. However, nowadays we have a newer or updated way of quantifying pelvic organ prolapse. In 1996, the International Continence Society, the American Urogynecologic Society, and the Society of Gynecologic Surgeons adopted a standardized terminology for the description of female pelvic organ prolapse and pelvic floor dysfunction. This is an objective site-specific system for describing, quantifying, and staging pelvic support and was developed to enhance both clinical and academic communication with respect to individual patients and populations of patients. This terminology replaces terms such as cystocele, rectocele, enterocele, and urethrovesical junctions with precise descriptions relating to specific anatomic landmarks. So now, this is the newest and the most updated way of quantifying or quantitatively describing pelvic organ prolapse, and this is what we call the POP-Q system. So in here, we have 6 sites in the POP-Q system. That's point AA, point BA, point C, point D, point AP, and point BP. So we'll discuss each of these 6 sites. Point AA is a point located in the midline of the anterior wall, 3 centimeters proximal to the urethral meatus, and is roughly the location of the urethrovesical crease. Point BA represents the most distal portion or the most distal position of any part of the anterior vaginal wall. Point C represents either the most distal edge of the cervix or the leading edge or apex of the vagina if a hysterectomy has been performed. Point D represents the location of the posterior fornix or the pouch of Douglas in a woman with a cervix. Point BP is a point most distal of any part of the upper posterior vaginal wall. And lastly, point AP is a point located in the midline of the posterior vaginal wall, 3 centimeters proximal to the hymen. PB is the length of the perineal body between the posterior vagina and the rectum. And finally, GH is the genital hiatus measurement from the urethra to the posterior vagina. All of these landmarks are measured during straining, and the most severe prolapse measurement on any of the vaginal walls can then be used to assign the stage of the prolapse. This is a summary of all the landmarks or the 6 sites that we have discussed so far. So after discussing the 6 sites or the landmarks, this is how we stage the pelvic organ prolapse using the POP-Q system. So for stage 0, no prolapse is demonstrated. Stage 1, the most distal portion of the prolapse is more than 1 centimeter above the level of the hymen. Stage 2, the most distal portion of the prolapse is less than 1 cm proximal or distal to the plane of the hymen. Stage 3, the most distal portion of the prolapse is more than 1 centimeter below the plane of the hymen, but protrudes no farther than 2 centimeters less than the total vaginal length in centimeters. And finally, stage 4 or PROCIDENTIA, essentially complete eversion of the total length of the lower genital tract. This is just a summary of the staging system that we have used both in the past and now the most updated quantitative description of POP, which is the POP-Q system. Now, there are different types of pelvic organ prolapse. Depends on which organs are involved, whether the organs which are adjacent to the anterior vaginal wall, which are the bladder and the urethra, or are the organs involved adjacent to the posterior vaginal wall, and this includes the rectum, or are the organs involved in the central location, which is the uterus or the cervix. Now, for the anterior vaginal wall prolapse, we have here cystocele and urethrocoele. The loss of anterior vaginal wall support is the most common site of primary pelvic organ prolapse. Normal support of the anterior vaginal wall depends on level 1 apical support and level 2 support from the endopelvic connective tissue and its attachment to the bony pelvis and pelvic muscles. Anterior vaginal wall prolapse can be associated with stress urinary incontinence from urethral hypermobility or urinary retention from urethral kinking that causes obstruction. Cystocele is the protrusion of the bladder into the vagina, signifying the relaxation of fascial supports of the anterior vaginal wall. Urethrocoele, on the other hand, is the protrusion of the urethra into the vagina. And these are or may be caused by fascial breaks. Either lateral breaks correspond to paravaginal defects, apical detachments from the pubocervical fascia of the cervix or vaginal apex are transverse cystoceles, and distal attachments from near the pubic symphysis pubis appear as urethrocoeles or urethral hypermobility. So the symptoms of anterior vaginal wall prolapse include the following: sensation of fullness, pelvic pressure, vaginal bulge, feeling that organs are falling out, feeling of incomplete emptying with voiding, slow urinary stream, and urinary urgency. The signs of anterior vaginal wall prolapse include the following: a soft bulging mass of the anterior vaginal wall on internal examination. In some patients, this mass must be replaced manually before the patient can void, and this is what we call splinting. Strain, cough, or prolonged standing often accentuates the bulge, and often POP symptoms are less bothersome in the morning and then they worsen later in the day after upright activities due to gravity. The urethrocoele and the cystocele are best demonstrated with the patient in the lithotomy position. So we use a retractor or the posterior wall blade of a grave speculum to depress the posterior vaginal wall. The patient is then asked to strain or do the Valsalva maneuver, and the degree of the cystocele or urethrocoele is noted. The physician should palpate the bladder neck and note whether it is well supported. Diagnosis is best performed with the bladder at least partially filled, around 100 to 250 ml of fluid, and a standing exam with Valsalva maneuver often allows the physician to see the maximal descent of the pelvic organ prolapse. Treatment of anterior vaginal wall prolapse may be non-operative or operative depending on the patient preferences and goals. Now, if the patient is not bothered by the prolapse, it can be left alone and managed expectantly unless it is causing urinary retention or renal hydronephrosis. For women with mild pelvic organ prolapse, they may elect for non-operative management with pelvic floor physical therapy and Kegel exercises. For the non-operative treatment, this consists of supporting the herniation of the anterior vaginal wall with the use of a Smith-Hodge ring, a cube, inflatable pessaries, intermittent use of a large tampon, or Kegel exercises. Kegel exercises help to strengthen the pelvic floor musculature and thereby may relieve some of the pressure symptoms produced by the cystocele or urethrocoele. Kegel exercises are also known as pelvic floor exercise, which consists of repeatedly contracting and relaxing the muscles that form part of the pelvic floor. This exercise can be performed multiple times each day for several minutes at a time for 1 to 3 months to begin to have an effect. Now, how do you instruct the patient which specific muscle to target during Kegel's exercises? So you tell the patient to urinate and then abruptly, in the middle of urinating, abruptly hold that urinary stream. So that muscles used to hold that urinary stream are the same exact muscles that are involved with Kegel's exercises. So a younger woman with a large cystocele should be encouraged to avoid operative repair until she has completed her family. Occasionally, the abnormality is so uncomfortable that repair must be performed before childbearing is complete. If this is the case, then cesarean delivery should be considered for subsequent pregnancies. Operative repair of a cystocele is generally performed in conjunction with the repair of all other pelvic support defects. Now, we do operative repair only when the non-operative management has failed. Repair consists of anterior colporrhaphy, correction of uterine DESCENSUS or apical defect, and possibly posterior colporrhaphy for a possible rectocoele. Cystoscopy should be performed to assess bladder and urethral integrity after the procedure is completed. Now for the posterior vaginal wall prolapse, this includes rectocoele and enterocoele. For the rectocoele, the signs and symptoms include heavy pelvic pressure or falling out feeling of the vagina. They may complain of constipation and occasionally may need to splint the vagina with their fingers to effect a bowel movement. They may also have a feeling of incomplete emptying of the rectum at the time of bowel movement. Protrusion of the prolapse may worsen later in the day and be aggravated by prolonged standing or exertion due to gravity. To diagnose rectocoele, this is identified by retracting the anterior vaginal wall upward with one half of a Graves or Pedersen speculum and having the patient strain or do the Valsalva maneuver. The rectum will bulge into the vagina and this bulge may protrude through the introitus. The physician should then place one finger into the rectum and one in the vagina and palpate the defect. Often, the rectovaginal septum is paper thin and the rectocoele can be palpated to its upper margin. For the management of rectocoele, non-operative procedures include pessaries, Kegel exercises, and estrogen. Gastrointestinal symptoms must be thoroughly evaluated, including screening for colorectal cancer if appropriate. If constipation and straining are issues, then a dietary fiber and fluid intake review should be obtained. The patient should at least have 25 grams of fiber, 6 to 8 glasses of fluid, regular exercise, and allowing time for defecation after meals is recommended. Operative management of rectocoele involves posterior colporrhaphy. For enterocoele, this is the herniation of the pouch of Douglas or cul-de-sac between the uterosacral ligaments into the rectovaginal septum and usually contains small bowel. It frequently occurs after an abdominal or vaginal hysterectomy. Generally, this is the result of a weakened support for the pouch of Douglas and the loss of vaginal apical support by the uterosacral ligaments. Through hernia of the peritoneal cavity emanating from the pouch of Douglas between the uterosacral ligaments and into the rectovaginal septum. How to diagnose enterocoele? We notice this as a separate bulge above the rectocoele, and at times it may be large enough to prolapse through the vagina. So we do transillumination of the bulge, and through transillumination we visualize some small bowel shadows within the sac. For the management of enterocoele, enterocoeles may be reduced transabdominally as a primary procedure or at the time of other abdominal procedures. In the primary procedure, the sac should be reduced upward if possible and dissected free from the bladder and the rectum. If the uterosacral ligaments are present, this may be brought together in the midline and attached to the vaginal cuff after closing the anterior and posterior fascia of the vaginal apex. Concentric purse string sutures in the endopelvic fascia may obliterate the cul-de-sac. Enterocoeles may be managed expectantly if asymptomatic, or they can be treated with pessaries or surgery. Repair of the enterocoele can be carried out vaginally at the time of the posterior colporrhaphy and apical repair. The sac must then be dissected free of underlying tissue and isolated at its neck. The neck of the hernia is then sutured with a purse string O polyglycol or permanent suture ligature and the sac excised. Now finally, we have uterine prolapse or DESCENSUS, or what we call uterine PROCIDENTIA. This is associated with injuries of the endopelvic fascia including cardinal and uterosacral ligaments, as well as injury to the neuromuscular unit with relaxation of the pelvic floor muscles, particularly the levator ani muscles. So occasionally the prolapse is the result of increased intra-abdominal pressure, such as ascites or large pelvic or intra-abdominal tumors superimposed on poor pelvic supports. For the symptom of PROCIDENTIA, usually patients have a feeling of pelvic pressure and heaviness, or a feeling of fullness or falling out in the perineal area. In cases where the cervix and the uterus are low in the vaginal canal, the cervix may be seen protruding from the introitus, giving the patient the impression that the tumor is bulging out of her vagina. For the management of uterine prolapse, stage 1 uterine prolapse does not actually require therapy, especially if the patient is asymptomatic, unless of course when the patient is very uncomfortable. For stages 2 to 4, operative repair of the prolapse of the uterus and the cervix generally involves a vaginal hysterectomy with a vaginal vault suspension. In some women, the cervix is hypertrophied and elongated to the area of the introitus, but the supports of the uterus itself are intact. A cystocoele and rectocoele may be present, and operative repair can consist of a Manchester or Donald or Fothergill operation. This combines an anterior and posterior colporrhaphy with the amputation of the cervix and the use of the cardinal ligaments to support the anterior vaginal wall and bladder. This is ideal for elderly women with comorbid medical conditions who have an elongated cervix and well-supported uterus, because it is technically easier and has an shorter operative time than the vaginal hysterectomy. Now, for elderly women who are no longer sexually active, a simple procedure for reducing prolapse is an obliterative procedure which we call colpoclysis or the Lefort procedure. The classic partial colpoclysis procedure is described by Lefort, and this is why we call this also as Lefort procedure. This involves the removal of a strip of anterior and posterior vaginal wall with closure of the margins of the anterior and posterior wall to each other. The vaginal cavity is nearly completely closed, with small vaginal canals on either side of the opposed vaginal walls to allow drainage of any fluid from the cuff or the uterus. And since the vaginal cavity is completely closed, then this is only for, or ideal only for, elderly women who no longer are sexually active. Now, for elderly women with still with sexual contact or sexual coitus, then we can probably recommend doing a Goodall power modification of the Lefort operation, and this involves removal of a triangular piece of vaginal wall beginning at the cervical reflection or 1 centimeter above the vaginal scar at the base of the triangle, with the apex of the triangle just beneath the bladder neck anteriorly and just at the introitus posteriorly. In other words, we close the vagina but only the upper 1/3 of the vagina, thereby still allowing access for coitus. And this is ideal for relatively small prolapses, whereas the Lefort procedure or the original Lefort procedure or colpoclysis is best for larger prolapses. So, in summary, we have discussed the definition of pelvic organ prolapse. We also discussed the pathophysiology, the classification, the quantification of pelvic organ prolapse. We also discussed the different kinds of pelvic organ prolapse, such as the anterior vaginal wall prolapse in the form of urethrocoele and cystocoele, and posterior vaginal wall prolapse in the form of rectocoele and enterocoele, and finally, uterine prolapse. Thank you so much for watching, and please don't forget to subscribe in my YouTube channel, Ina Irabon, and my WordPress site, Doc Ina Obigaine. Thank you!